Good afternoon, everyone. Welcome to AHI Health Home September office hours. This is Travis Bethel, Operations Manager for the Adult Program, and I wanted to welcome everybody in today. As always, we're going to record this session and have it available on our AHI training page in the near future. If anybody's got anything they wanted to comment, questions, or discussion points throughout, please unmute yourself or use the chat box. So we'll get started. So we're going to talk today about K codes and transfers, touch on policy and procedure, our standing item of COVID-19 related topics, NetSmart, and then touch on the Health Home Business Intelligence Plan. Before we get into those areas, though, I wanted to take a moment to turn over to Ann Hutchinson. We have a addition to our staffing team to support the Health Home, and I wanted to turn it over to Ann to introduce that person.
Good afternoon, everyone. Just wanted to announce that Karen Ashline, the Associate Vice President of the Adirondacks ACO, is now providing executive leadership to the Health Home. I am sure the majority of you are already know Karen and are familiar with her from her extensive work in the North Country over the past several years, but wanted to give Karen an opportunity to introduce herself and to just kind of introduce her into her new role with the Health Home. So Karen, are you on?
I am. Thank you so much, Ann, and hi, everyone. Happy to really participate and join. I've been working in the region for about 11 years, really focused a lot of my time in the region on care coordination, so very much near and dear to my heart to be a part of the Health Home team. Over the last year, AHI and the ACO have looked at ways to be more efficient operationally and join resources, and this is another step in that direction. You all know that Mary McLaughlin is semi-retired, lucky Mary. But this gives me an opportunity to step in, and I don't see it changing your day-to-day work at all. I'm here to learn and be a support as I can, but you're under great leadership with the current team that you have. So again, happy to be here. I'm going to participate for about half an hour today, and then I need to jump off for another meeting, but look forward to working with all of you in the future.
Thank you very much, Karen, and welcome to the team.
Thanks.
So further information here, as usual, we have the listing of our Health Home staff or our team through the admin side on Health Home. So if anybody ever has any questions, please reach out through the Health Home email, and one of us will get back to you as soon as we can to answer anything you have. We're going to go in next to the K code and transfer discussion, and Jessica Robertson is going to take that. Jessica?
Hi, everybody. I'm here to talk about everyone's favorite thing, K codes. So I just wanted to talk about them today briefly because I wanted everyone to be aware that a youth who is under 21 but can still be served in an adult health home can actually have one of these codes attached. And if you look at the RE code sheet, it will tell you that it is compatible with Health Home, which it is. However, these youth have to be served by a children's CMA. So even if they are 20, but they do have these K codes, they would have to be served by a children's CMA. So you want to make sure that if you're an adult provider and you see a K code, that you reach out to the referral source and have a discussion with them about that code and either getting that code removed before you accept the referral or reaching out to that referral source to refer them to a children's provider. And then on the left-hand side of the screen, you can see that whole list of K codes, and it's going to be any one of those K codes that you see. So if you see any of those, that would be a red flag to stop before you process the referral. Okay, next slide, Jeff. Thanks. So on the other hand, if it's a children's CMA to a children's CMA, getting a referral with a K code, you always want to check e-paces when you accept a referral to see if this code is there. And then you need to be aware that with these codes, these children are enrolled in a very specific program with a very specific workflow. So if you were to accept a youth as a transfer or referral with one of these codes, that you need to be aware of the services that they're receiving and the documentation that you would have to collect before you accept and enroll the youth. What would happen would be that you would need to follow the Health Home CS transfer policy, and that would be applicable not just between Health Home and CS transfer, but CMA to CMA, Health Home to Health Home. You have to work on a smooth transition, because once you accept a referral for a youth that has a K code, you then become responsible for the oversight of that youth. That youth is then assigned to you. You are responsible for that workflow. So if the youth had a assigned K code but wants to be disenrolled from HCBS but remain in Health Home, it is the responsibility of the CMA transferring that case to have those K codes removed prior to transfer. So if you were to receive a case being another children's CMA or adult CMA and you see that K code on there, you need to reach out to the referral source and have the discussion as to whether or not that youth is going to continue with HCBS or if they're being disenrolled. And if they are disenrolled, it is the responsibility of the referrer to have those K codes removed. Once you accept that case with a K code, you then become responsible for the oversight of that youth. So this is covered in a number of policies. It's covered in our Health Home CS transfer policy, our waiver policy, and our HCBS waiver disenrollment policy. But if you ever have any questions when you receive a referral or a transfer about a youth with a K code, you could always reach out to the Health Home and we can walk through to see what happens, because we have had instances where we've had youth get referred who had no idea they were actually eligible for the service or receiving it. So if you have any questions at any time, you can reach out to us and we can do some backtracking to see the status of those codes and what next steps should happen. Does anyone have any questions?
Okay, Jessica, well, thank you. And again, if anybody has questions, they want to reach out separately, please do so as always, and we will connect with you.
Yes, please reach out if you have any questions. I will be happy to answer them.
So next, we'll just touch on policy and procedure. Since our last meeting in August, we have not had any updates that have gone out to the network, but I just wanted to take a moment. You know, we usually put this slide up to just show what's coming, what has come out. You know, we have some upcoming policy updates that are pending, and you know, just to point out also that we have our policy and procedure page on our HI website through the Health Home policy and procedures page, and that's accessible at any point for folks if they want to get on and check out what we have as most current policies. But did anybody have any questions on any policies currently that are out there? I will be speaking on the next slide about a new change that's coming out on the Health Home Plus SMI AOT that just came from OMH in the last couple of weeks. But before I get to that, did anybody have any questions or thoughts or anything they wanted to bring up around current policies and procedures? Okay, so then we'll move on to the Health Home Plus SMI and AOT. So OMH just sent out, and it's effective of September. It's been in the last week and a half, I believe, when they sent the memorandum out. They're expanding eligibility criterion for Health Home Plus SMI and AOT to include adults discharged from State Psychiatric Center or Central New York Psychiatric Center Corrections-Based Mental Health Unit. And if that person resides in a state-operated residence located on a psychiatric campus or grounds, they're they're not restricted any longer. Those folks are not any longer restricted from receiving Health Home Plus services. So that's an additional eligibility criteria that a person can meet if they fall into this circumstance. So we will be sending out an update to that policy and procedure for Health Home Plus, SMI, and AOT in the very near future, just to reference this as one of the eligibility components, and we'll get that out to the network. But I wanted to get this to you sooner than that getting out, just so folks were aware. Moving on to COVID-19, I brought this up last month. I just want to reiterate it again. As of 10/24/21, it's gonna come to that 60-day deadline from the August 4th memorandum that OMH had sent out. You can see that screenshot over to the right, just highlighting that there's an expectation that the face-to-face requirement for Health Home Plus will be in full effect. So as of that October 24th date of 21, and that organizations that are providing Health Home Plus SMI services to adults should be striving for that 2 face-to-face contact, 4 contacts a month with that member, 2 of which have to be face-to-face. So I know organizations are working toward that, but just to reiterate that this is something that came through OMH's guidance, that this has to be back into effect. There is an ability to still do telehealth related, telephonic related interaction with those folks who fall into the SMI Health Home Plus category, but you have to do a risk benefit assessment. And I mentioned this link last time when we had last month's office hours. I just wanted to provide it again for folks. That references, I think it's beginning on page 4, going into 5 and 6, the in-person visit assessment criterion. And if a person falls into one of those criterion, then you can go ahead and have that telehealth or telephonic communication, but that has to be documented into the member's record. I know that's something that we as a health home have been encouraging and asking folks to do for anybody for health home status throughout the pandemic, but in particular for Health Home Plus, this is an OMH request on top of the general guidance to document into the member's record. So just want to make sure folks are following that guidance. And then there's also a reiteration of wearing masks and continue 6 feet physical distancing for all in-person contacts, which I know folks have been following throughout this whole pandemic, but just want to reiterate that that is still in effect. In particular to Health Home and the waivers that are in place, they continue. DOH has not put forward any change in those waivers for face-to-face. This is an OMH specific to the Health Home Plus SMI. When DOH does come forward with any change to that waiver that was put in place for the pandemic in regards to face-to-face and consents, we will be sure to get that information to everyone. We are being told that they're going to give, meaning DOH, a 60-day window for organizations to start to acclimate to prior policy and procedures once that waiver is pulled back. So there will be a block of time that we'll be able to adjust to.
Travis.
Yes.
So I'm doing Health Home Plus. We have been doing full face-to-face, but in our area, it's the rate is really high. Lots of people are on quarantine. So is there a thought that it may go backwards for the Health Home Plus, like Health Home Plus?
At this point, we're not getting that type of information from OMH, but I would say if numbers do continue to increase and there is a spike that's considerate and it's gaining steam, I would imagine there would be a close look at that documentation and guidance that's been put forth, and I would hope at that point there would be a reconsideration, but there's nothing that's come to us at this point that's indicated otherwise.
Okay, so by the end of October, we should be full face-to-face.
Unless you find that there's a health or safety risk for the staff or the person that you're working with, the member or the client. So you just want to make sure you document that clearly, why the face-to-face did not occur, if that were the case.
Thank you.
Yes. Any other questions, comments, or discussion around this particular item for Health and Plus SMI?
Yeah, can you hear me?
Yes.
Yeah, how is that gonna work with it starting on the 24th of the month? If we get 3 contacts with them and they're non-face-to-face, and then the 4th contact occurs after the 24th, how does that work?
Well, I think the idea is that there's been, since August 4th, this guidance put forth that organization has been striving to work toward the face-to-face in preparation for that October 24th date. So that's why we've talked about it the last couple office hours. And you know, to help organizations to get prepared. Clearly, if there's
No, I understand that. I'm just
right,
saying that the date was set at the 24th. So I'm
yeah,
just curious how that's gonna. So the
that's a date that
expectation then
was
is actually that we start getting the face-to-faces prior to the 24th, because it's unrealistic to get 4 of them in afterwards.
right, right. So you should be working now to work toward that 2 face-to-face contacts in a month. Now that's moving forward. It's going to be in your 30 or 31 day window on each month, but by
Well,
October
yeah, I
24th,
understand that. So
right.
it's a little unclear, but okay, that clears it up. Thank you.
Why wouldn't they just allow the last visit to be face to face and the 3 prior to be, you know, telephonic? I mean, that's the cutoff, and then you had to do the face to face. Why wouldn't
Yeah,
that
see
then
that.
be a billable month?
I'm not
Yeah,
sure
well,
why
I mean,
they
that was
chose
my
it.
understanding as well.
Yeah, I'm not sure why they chose the 24th as the cutoff date, but August 4th said 60 days from this date. You know, we're going to have organizations have to meet this requirement, the 2 face-to-face contacts in a month. So that tells me that people, you know, organizations would be given that 60-day window to strive to get that in prior to the 24th by the October date, and then moving forward, you have your 4 contacts a month, 2 of which are face-to-face. Is that helping or not helping?
It clears it up, but I don't know how helpful it was.
Right. I unfortunately don't know why they chose the 24th to be the cutoff date. I don't have an answer for that,
Well, because
unfortunately.
possibly because they had been talking about the 60 days for a long time now, and then they stuck with it as opposed to doing something that was more plausible, like saying the start of a month.
Right, right. Yeah, clearly there's some method to the madness behind their decision. I just hasn't been shared to my knowledge as to why that date was the date that was identified.
Oh, yeah, clearly it has nothing to do with this is their policy.
Yeah.
But all right, well, thank you.
Yes. Any other questions or comments around this particular topic?
Can you put the link to this risk benefit assessment in the chat?
Yes. Yeah. See if I can do it now. I can't while I have the PowerPoint up the way I have it, but what I can do is I can send the link out when I send out the slide deck after the office hours. Does that work for folks? Unless one of my colleagues can pull it and put it into the chat, then we can do it that way.
Travis, I can do it.
Thank you, Taylor. So there's a question in the chat that says, how will that work with it starting towards the end of the month, but not at the start of the month? Were we able to answer that, or is that still something
I'm sorry, Trav. That was me. I'm sorry.
That's
been addressed.
okay.
Thank you.
I just want to make sure I was capturing it.
Oh, no, thank you, though.
Yes. Okay. So now we're going to move on to a new workflow that NetSmart's put forward around Okta user reactivation, password resets, and then MFA resets. So in the past, the health home was like the middleman, the middle person, as far as when the end user was having an issue with one of these areas, and then we come through the health home, and then we get in touch with NetSmart, and then NetSmart would come back to the health home, we go back to the user, and it was just like this. Could be very confusing. It could be drawn out, waiting to hear from NetSmart, vice versa. So NetSmart actually came up to streamline the process to help make it a little more friendly for the user and a little more responsive. So just wanted to walk through those changes so folks are aware. So when the user enters the case with the health home for health home support, the health home then turns around and says, okay, NetSmart, we got a request. And then what's going to be needed during that is the end user's name, phone, and email address. And then NetSmart will take that action and they'll go to the end user. So they're going to communicate with the user directly, not back with the health home initially. So once we put that work order in with NetSmart, when you reached out to us with an issue, they'll complete the action. They'll reach out to the user, make sure you can get back on. You were successful. Was there still an issue? And then after that, once they've gotten a response from the user, then NetSmart will go to inform the health home of that interaction. And then they're going to set a status for it. Basically, was the case resolved? An example here was a pending verification once the action and awaiting the end user to confirm. And then NetSmart's going to wait to hear back from that user to update that accordingly. So on a health home end, once that stuff has happened with NetSmart and the end user, the health home's made aware at that point, and they're going to confirm that if it's a closed, so that would be clicking on the health home would have these actions, not the user. So I'm just showing this to show you the transparency of the workflow. But the accept solution, the health home would click that if everybody was happy at the end, the issue was resolved, the concern resolved. If not, then there's the resume case button. It's a little blurry here, I apologize. But the health home would click on that to say, there's still an issue, and have commentary to put in the text box. So as much as possible, this process is to pull out that end user and take them out of the, the health home out of the middle, so that the end user and NetSmart have more of a direct dialogue. So we're hopeful that that's going to be helpful for folks. It's certainly, from the health home end, has helped in respect of, we've got an end user waiting for a response, and they're following up with the health home, and we're trying to follow up with them, but we're waiting for NetSmart. They're the one that's actually working on the issue on the back end. It just takes out that middleman piece, and helps the process go directly to the sources. So that's the NetSmart change with MFA, OCTA, and password reset. Next thing I want to talk about was adding and maintaining member programs. So we just want to ask folks that when you're in NetSmart and you're in the programs tab, that you're adding applicable programs that the person's enrolled in, and that's kept up to date in NetSmart. So for example, if someone becomes Health Home Plus eligible, that's entered into the active programs category. If the person's HARP, if they're health home program itself once they've enrolled, so that's stuff in there and that's active. We don't have a situation where we would want to have a members program have an end date unless that person's no longer in the program. So we have had some situations come up when health home's been reviewing data and pulling reports where there have been end dates on certain members on programs when in fact that member was not disenrolled in the programs, but they're showing an end date. So that's created issues, on the back end when we're looking at those things and pulling reports. So what we're asking at this point for folks who have that, if they would go and go in and close out those active Health Home Plus programs. So if you have any programs in NetSmart that have future end dates that are populated for active Health Home Plus programs, please go in and remove that future end date. So for those folks that fall into that, please go and do that for us, and we do appreciate that. Were there any questions around programs or just how to put a program in or anything around program tab itself? No? Okay. Well, if you have any questions, please reach out. The next thing with NetSmart is around transferring between episodes. Last month I had mentioned that NetSmart was going to be turning that function off. Well, they have done so, but I wanted to just point out what that means. So that ability is as of September. So any newly enrolled members as of September for identified problems that would then go to another episode. Let's say they leave AHI's Care Management Agency and they go to Warren Washington Association for Mental Health next. That's not going to automatically, those problems are not going to automatically transfer for that member in that circumstance. They would have to be re-entered for when the next organization picks up that person, starts working with them. But if it's someone that was prior to September, prior to NetSmart turning that function off, that member would have their problems transfer from episode to episode. So it's anybody moving forward from September basically is when that manual input would be occurring. Anybody have anything questions around member problems or transferring? If you do run into anything with it, please reach out and then we can troubleshoot. And then the last thing I had today, just Data Den. I know we've been talking about this for a few months now. There was a demonstration initially just to introduce it when it was called Power BI, the original name of the platform. We've renamed it Data Den. We were trying to amp up as an health home to provide a training to the network. But then we took a pause and we've really been looking at testing and data validation and really working through those items just to make sure that everything's as current as possible and accurate. So that training is going to be coming forward. We're looking to get those dates out to folks as soon as we can, but right now we're still pushing through the final phases of testing and data validation. And I didn't know if you wanted to add anything to that.
Nope, that's 100% accurate. So we are testing internal access and going through validation exercises. We are kind of on the cusp of testing external user sign-on and access. So we are making progress slow and steady, and we're very excited to roll it out to the network.
Excellent. Did anybody have anything they wanted to talk about that we haven't brought up today, or just something that anybody wanted to talk through? Any questions? I didn't have anything further as far as topics for today.
I have something, Travis.
Yes.
So I didn't know if AHI took into effect, like, our county is high for numbers. I know you go based on OMH, but if there's stipulations that AHI could put in place in case, other counties spike when we're not spiking, and it's not statewide. Does that make sense?
It does. I'm going to pitch this one to Ann, though. Ann, I don't want to put you on the spot, but I know we follow the OMH guidance, and I think one of the things before I pitched Ann that we always say as a health home, health and safety is primary, and that should be first and foremost for anyone. I think the safest thing would be is to document. If there was a decision by your organization, to not do face-to-face, to pause on face-to-face for whatever that reason would be.
So our agency just is on that. They've went back to telehealth. I don't remember what date that was. Maybe Val can tell me. So that's where we were looking for documentation, is that our home agency is back to that because
Okay.
of the numbers.
Yeah, I think, at that point you have an organizational decision. That whole documentation piece is key. OMH is putting forth this guidance. We're relaying that information as a health home. But, health and safety is primary for anyone, I would say. Anne, would you have anything to add to that?
No, I think everything that you said made sense, Travis. I mean, if your organization has made a executive level decision to go back to telehealth, and that is absolutely the guidance that you would be expected to adhere to. Um, the caveat is that for the health home program, and specifically for the Health Home Plus population, this particular OMH guidance is what we need to follow. I would again kind of reiterate what Travis said earlier, that the state in their guidance had basically given themselves the right to extend that date as needed. So, we shall see what that holds, and if that provides any additional extensions. But I mean, as we've said from the beginning of a pandemic, where this is new territory for all of us, and we all just have to adhere to the first and foremost the guidance of our internal organization, and take into consideration the guidance from the state partners.
Okay, I have one more. I'm sorry. So, if we are placed on quarantine, because I'm vaccinated, I'm not technically quarantined, but if I had somebody in my household, I would not feel right going to somebody's house. So how do we document that in a note? Like, we still are required to, do our job, but if we can do it remote, we can do it remote. Does that make sense?
I would just document, this is Lori Bishop from AMH. I mean, I would document that you're the actual risk, right? You know what I mean? Due to, a high degree of exposure or that sort of thing, care manager, unable to have direct contact presently will be doing telehealth till clear, something like that.
Okay. Yeah, that's what I was thinking, but I just wanted to get it from, the top.
Yeah, and really, again, in these instances, first and foremost, you need to follow your own organization's direction. That is first and foremost. That would be what I consider trump if we're playing a game here. If AHI as an organization gave us direction that conflicted with OMH, I would of course bring that to the attention of the leadership of our organization, but we would need to follow the direction of our home organization.
That's great questions. There's a question that came through, just inquiring about, so if an agency makes a decision not to do in-person visits based on infection numbers in their particular county, would they still be able to bill Health Home Plus? I think that's going to come down into what Ann just said, but also from the billing side of things. Was that risk assessment done? The link was just put in the chat for everybody. Was it documented in the member's record why that visit did not occur? So, I think it's coming down to that loophole that they're giving at this point. As long as you've done that assessment with the member and that face-to-face didn't occur due to that risk factoring in, you should at this point be able to bill out to Health Home Plus. But if there's not documentation supporting that decision, I think that's where the issue would start to come up for folks based on the way I'm interpreting that memorandum at this point. Does that help answer that question? There's another chat that's saying, is this also for kids? There's been no guidance on kids yet, to my knowledge. This is specific to adults. The Health Home Plus SMI piece that we're talking about is specific to the adults. Lori, that's a great point. The risk assessments to keep everyone safe, right? So health and safety is first and foremost for everyone involved. Any other questions or comments? This is all great stuff. I mean, these are real questions, right? Numbers are spiking in certain areas. I'm hopeful that OMH will look at that if it continues to spike and becomes a greater issue throughout the state, and at that point make a decision a little different than what's put in writing at this point. But I'm not hearing of anything currently that would be changing that.
Yeah, and I would just kind of follow up with just saying again, just make sure you're following the guidance of your home organization. We don't ever want to provide any guidance through these channels and have folks kind of take that as what they should be following. Always follow what the guidance from your home organization, and then you can bring this back to your leadership as far as what the health home related or OMH policy has been relayed. But by all means, always follow your home organization policy and procedure as it relates to pandemic.
Yeah. And I think too, I mean, a lot of the organizations on the call today and through our network are, provisionally designated or already designated. So that's pretty much the majority of our CMAs in the network. And, every month there's a questionnaire that comes out from OMH on assessment of how many folks have you seen, to what extent have you met the face-to-face requirement for Health and Plus? What were the obstacles if you haven't? So that's all data, that's all information that they're collecting, which, I'm sure they're looking at that as a whole. So continue, if you've got boundaries that are preventing you and you're documenting it in the member's record as they're requesting, but also through the monthly surveys that they're conducting currently, I would put that information in there too. What were the things that prevented you to meet those requirements if you weren't able to? We've done that with our own internal organization through HI. We had certain things factor in over the last couple months where we've put that into that survey just so that they're aware of what circumstances were.
So if an agency is going back to remote, should we notify AHI of that so you're aware?
Anne, is that something that you would like to have happen?
I don't think it would hurt if you're not able to provide face-to-face and your agency has gone back to remote. I don't think that would be a bad thing for us to know.
Okay, thank you.
Anybody else have anything? Okay, well, I want to thank you all again for your time today, and stay safe, and thank you for all that you do, as always, and we'll talk to you all soon. Take care.